Okay, hopefully this works. Just had some error messages then as we started. That's never a good. That's never a good start. It looks okay from my end, so let me know if you can hear everything okay, and then we'll get going. Good morning, everybody. Hopefully, we'll have some messages coming through. No, we don't. Yes, good. Rahul, good to see you again. Good evening. Good to see you from India. Thank you for coming back again. Morning, Jules. Morning. Let's pop you on here. There we go. Just to show people that it is real. Jules, morning. Good to see you. Morning, Tris. We had a great day yesterday. Me and Tris and Stevie. I don't know whether he's in today. We did a little course yesterday at my training venue in Ludlow. Joanna, good to see you as well. Welcome. Tonbridge, is that Claire? I think that might be Claire is in as well. Good morning. So, welcome back. We started on the elbow bone anatomy last week, and we're going to build on that. And what I've done with the musculature is I've focused on the muscles that act on the elbow only. And so the muscle section might seem a little bit short, but what we'll do is we'll pick up the rest of the muscles that then act on the wrist, which obviously attach into the elbow when we do the wrist and the hand. It kind of makes sense that way. So hopefully that makes sense. I thought it might be you. Welcome back. Hi, Steph. Good to see you as well. Got our usual crew in. Right, so let's get going. This is where we've finished. So we were here and we were looking at all of the various different parts of the elbow and the specifically the bony anatomy. Morning, Caroline. Morning. Hope your dog's okay. Bless her. And Becky, good to see you as well. Morning. We've got a right bunch in this morning. Everybody loves the elbow. I think when we get to elbow, wrist, and hand, it was one of those areas where I really struggled when I first qualified because I don't think we covered it in that much depth really when I did my course. So yeah, it was an area where I really had to study to get to grips with it. And I've been doing a lot of treatment with shockwave around the elbow, and you need to know your anatomy for that, and all the little tips and tricks. So hopefully we'll give you those as we go through. So this is where we were. We were looking at these areas here, the supracondylar ridges. I'll just do a quick recap from last week, and these are important when we start to look at the wrist anatomy and grip problems like with tennis elbow, golfer's elbow, because this is where those muscles or some of those muscles will attach. And again, sometimes that's a bit like, oh, I didn't realize that. But there's there are two with tennis elbow specifically. There are two main muscles that are a problem: extensor carpi radialis brevis and extensor carpi radialis longus. Apologies if you've never heard those muscles before. They're really long names. But if you break it down, we've got extensor, so it extends. Carpi, the carpals, which are the wrist bones. Radialis, it goes along the radius. And brevis means short. Yeah, and longus means long. So you've got a short muscle that goes along the radius and extends the wrist. And then a long muscle that goes along the radius and extends the wrist. So yeah, it's when you break it down, hopefully it makes it a bit easier to understand. We were looking at this area here. So this is the radial fossa. A fossa is a dip in the bone, and usually it is filled with something. So either a muscle. So for example, in the iliac fossa, you've got the muscle there, or it's because it's near a joint and a bit of another bone. When you shorten the angle of the joint, a bit of another bone goes into that dip. All right, so we've got the radial fossa, which is here. So that part of the radial head will go into that dip. Okay, so when you flex your elbow, there's quite a bit of soft tissue in the way anyway, so you can't fully flex unless you've got very, very small biceps. And then we've got this area here, the coronoid fossa, and that lump there on the ulna, that's called the coronoid process. So when you flex the elbow, so when you shorten the angle of the joint, that knobbly bit there will go into that gap there. Okay. The shape of the ulna as well. So we've got like a double bump, yeah, on this trochlea, which is the humerus bone, and it fits into the groove of the ulna here. So it all kind of merges in quite nicely, and then the capitulum is nice and round for the round head of the radial head. All right, so it all fits together quite nicely. Other areas you need to be aware of, and we looked at these last week as well, the lateral epicondyle. So epi means upon, and a condyle is a knuckle. So this area here, we've got the lateral condyle, which is the kind of main shape of the bone. But then on top of that condyle, there's a little projection, which is the lateral epicondyle. And then we've got one on the medial aspect as well. The medial aspect is quite big. You can feel that one quite easily. So if you have a feel of the down your humerus bone all the way to the end, and the way that I usually describe this, it's like a cartoon bone. Yeah, so if you think about those bones that you used to see in, I don't know, Scooby-Doo or something like that, and they were the typical kind of bone shape, like the emojis that you get on your phone for a bone. That's basically what it feels like when you get down to the end of the humerus. So you can feel the shaft of the bone, and then when you get to the end, it starts to widen. And then when it starts to widen, you can feel the widest points, and those are your epicondyles. All right, so we were having a feel of those last week. Right, so let's have a look. Oh, why is that not working? Oh, that's really weird. It's trying to move something else. Bear with me a second. See if I can do that one. No, hold on. Get rid of that one. Try that. There we go. Sorry. All stuff you can't see. And oh god, got so many buttons on this to try and get everything in. So this is the back of an elbow. We did have a brief look at this last time, or described it last time. So around the back here, we've got another fossa, so another dip, and that's where the elbow point, so this bit here, the olecranon process, when you extend your elbow, it will slide into the olecranon fossa. So when your elbow's bent, you can't see it on this image because it's obviously straightened, but there's a dip here behind this process. And that is often an area where you may get a fracture. Okay, so a fracture dislocation of the elbow can occur around, well, it can occur anywhere in terms of fractures, but really quite common around this area, and the radial head as well. So if you're dealing with orthopedic stuff, then kind of a couple of areas to be aware of. There's your medial supracondylar ridge from the back. There's your lateral from the back, lateral epicondyle, medial. And then what we looked at last week, that's your olecranon, that's your medial epicondyle. So olecranon, medial epicondyle. And if you put your thumb on the medial epicondyle, middle finger on the olecranon, and then in the middle, if you give it a bit of a push, there's a groove in there, which is that bit there. And it's called the ulnar groove because that is where your ulnar nerve goes through. Okay, so it passes around that groove on its way down to your little finger and your ring finger. Okay, so that's an important area as well, because again, you can do some clinical tests around there. So if someone's got pins and needles tingling, there can be an issue at the ulnar groove. There is a ligament that goes over the ulnar nerve to hold it in place, and if you have a problem with that ligament, it ruptures, then the ulnar nerve can flick out of the groove. Okay, so that's something to feel for as you're examining the elbow. Can you feel like something flicking? But also you might want to do a tap on that area to see whether it's reproducing the symptoms into the little finger and the ring finger. That's called a tinal tap. Okay, so there are certain areas of the body where the nerves are really superficial and they may become compressed. Right, so we can test that to see if it reproduces the symptoms. But yeah, so that's that area there. It's quite an easy one to find, and it's basically your funny bone. Yeah, so when you hit your funny bone, that's what you're hitting. Right, these are bits that we didn't cover, so I'm just going to finish these off in terms of the bony landmarks. The proximal radius, so this is the radius bone. The proximal bit is the bit that's closest to your body. Okay, the distal part is furthest away, proximal is closest to you. The medial head articulates with the radial notch of the ulna. Okay, so we've got a little notch here in the ulna, and there's your radial head, and can you see there's like this little dip? Yeah, the radius is on the thumb side. The radial tuberosity is a large bump on the medial side of the neck, so that's that bit there. Yeah, so we've got the radial tuberosity, which is an important landmark because that is where your biceps brachii attaches. Now, when we start to see the muscles and we start to layer them on, you'll realize with the biceps, it doesn't just go into that point and then that's it. The bicep tendon goes into that point and then spreads across the forearm into the fascia that covers the forearm. So it's quite a wide distribution. It's a very powerful muscle, your biceps. Very important as well, because obviously if you can't do that action, then you can't feed yourself. So it's really important that we can do elbow flexion. So yeah, that's the kind of arrangement at the proximal radius. The proximal ulna is that double bump that we were talking about before. So the coronoid and then the double bump attaching onto the trochlea. So we've got the longest and medial of two forearm bones. That's your ulna. So it's on the, if you're in the anatomical position, so that's with your palms facing forward, it's on the inside. It's on the medial side. So this bit here, okay? Radius is on the thumb side in the anatomical position. Yeah. When you turn your palm over, it twists the bones and then it becomes really confusing. So if you go back to anatomical position, palms facing forward, then you can't go wrong. Okay. We've got the olecranon process fits into the olecranon fossa. So that's that bit there we were talking about before. We'll have a look at this on the video in a second. And then the coronoid process, so that bump there, that fits into the coronoid fossa on the anterior aspect of the elbow joint, so the front of the elbow joint. Between these two is the trochlear notch, and this articulates with the trochlea of the humerus. Okay, so that's that region there that articulates with the trochlea. Okay, so those are your main kind of bony landmarks. A lot of these you can't, there's no way you can feel them. Yeah, so being able to palpate the radial tuberosity, it's going to be really difficult because there's a lot of musculature there. The bicep tendon's pretty big as well, so you'll be able to track the bicep tendon down into that point, but you won't necessarily be able to feel the lump like you can feel, say, the acromion. Yeah, it's just not that superficial. It's quite tucked away. We've got the neck of the radius, head of the radius just here, coronoid process, radial notch, okay, so around this area here, articulating with the radial head, and then the ulnar tuberosity as well. So we've got some key landmarks, but again, you can't really palpate these, they're too deep. These ones, some of them you can, so you can feel the olecranon process, that's really easy. Okay, so that's on the back there, your elbow point. Radial notch is too deep, but that's the articulation with the radial head and the ulnar. Neck of the radius just from the back. The head of the radius, you can palpate that. So if you have a feel on the outside of your, feel for the lateral epicondyle, go distally, so away from your body, just about a centimetre from your lateral epicondyle, and then start to rotate your hand. Okay, so if you feel like this, finger on the lateral epicondyle, just drop that next finger down, just literally a finger width, start to rotate, and then you should be able to feel the radial head spinning. And if you've got an old elbow that's done a lot of manual therapy over the years like mine, then it creaks quite a bit and groans quite a bit. Okay, so that's that area just there. Right, let's have a look at the videos again for that. So this is just finishing off the elbow bones and landmarks. There's a few little bits on the ligaments on this as well. So scapula, humeral head, shaft of the humerus. We did all that a few weeks ago when we looked at the shoulder. As you come down here into the elbow joint, we've got 3 joints, if you remember. So we've got the humero-radial joint, so from the humerus to the radius, humero-ulnar joint, and then the radio-ulnar joint as well. Okay, so we've got radius joining onto the ulnar, radius joining onto the humerus, ulnar onto the humerus as well. And we'll talk a bit more about that as we go. You can see the shape of these bones, so that's the radius there. When the hand is in that position, so kind of like halfway between fully pronated and fully supinated, and the way to remember those is if you turn your hand over, you have a bowl of soup. And then turn your hand over as pronated. So if you remember the soup, then the other one is easy to remember then, just pronation. And so what will happen is obviously this area here is going to stay still. The radial head will spin, and then that end of the radius will rotate on this bit of the ulnar. So if you're thinking about where bones are and you're palpating, if you've got the hand pronated and you're thinking about things in the anatomical position, they're going to be all over the place because you've got the hand in the wrong place. Yeah. So easy to start is with the hand fully supinated. Okay. So then you can get to grips with the anatomy that way to start with. So humerus, radius, ulnar. These are your epicondyles on the side here. There's your capitulum and your trochlea. There's your lateral epicondyle, medial epicondyle there. And you can see it's quite a lot bigger on the medial side. I mean, obviously you can feel it as well. There's a supracondylar ridge. Again, sometimes they're given different names, epicondylar ridge. And then this is the joint with a little bit of connective tissue on. So there's your radial head. Yeah. There's that will be your capitulum, and you can see the glistening white of the cartilage. All right, and then the end of the humeral head is kind of like a bowl. It's a bit like a shallow dish. Yeah. So when it slots into the capitulum, it can rotate upwards and backwards. So you get that flexion extension, and you get rotation from pronation supination as well. And you'll see that as we go. So this needs quite a bit of stabilization from ligamentous structures because it moves so much. Yeah, we've got spinning action and hinge action, so we need a couple of ligaments to hold that in place. Not so much with the ulnar. And then there you can see the cartilage again. There's the coronoid fossa. And then round the back, there's the olecranon and the olecranon fossa just there. Yeah. So that will slot into there. You've got radial collateral ligament. We'll talk a bit more about that in a second. And then you'll be able to see the spinning motion of the radial head just there. Cool. So that's how everything fits together. Yeah. We're going to break that down a little bit for you now. Okay, let me know if you've got any questions as we go. Okay, so these are taken from the Trail Guide to the Body book, and if you don't have that book, recommend it. It's a nice way to start learning anatomy and especially palpation, because literally it has got a trail guide. So it will go right from the olecranon process that you can feel really easily, move in this direction, then come across in this direction, and then you'll be able to feel different landmarks really easily. Okay, so we've got three major ligaments of the elbow: the ulnar collateral ligament, and sometimes it's called the lateral collateral ligament, which is a bit annoying because so is the ligament in the knee. Okay, it's called the same, and so are the ligaments in your fingers. Okay, so that is why we try to be a bit more specific with this region, and we'll call it the ulnar collateral ligament rather than the lateral collateral, or medial collateral in that case. Radial collateral ligament on the lateral aspect, RCL. So yeah, sometimes they're called LCL and MCL. So medial side would be ulnar, lateral side would be radius. And then annular ligament, annular, it's like annual, so all year round. And this ligament wraps around your radial head to allow the radial head to spin. All right, and we'll have a look at that in a second. It's quite amazing, that actually. So these are the attachments for those ligaments. So the ulnar collateral is a triangular shaped ligament, also referred to as the medial collateral, as I said, and you're going to get a connection from the medial epicondyle, which we felt earlier, onto the coronoid process. So that's that sticky out bit of the on the anterior part of the ulna. Okay, then the radial collateral, often referred to as the lateral collateral on the outside, lateral epicondyle of the humerus, and then it attaches to the olecranon process and the annular ligament as well. Okay, so remember I said the radial head needs a bit more stability because it rotates and it flexes and extends. So we've got a couple of ligaments in place there to hold that bone in place so it can do the jobs it needs to do. Annular wraps around the head and neck of the radius and allows that spinning motion to occur. Supports the proximal radius against the ulna during pronation and supination. Okay, and then we've got its attachments on the radial notch anteriorly and posteriorly, and we'll see that in a second. So let's have a look at that. Just get rid of that one. This hopefully should be the annular ligament, so we'll do that one first. I know you shouldn't have favourites, but this is probably my favourite ligament. Okay, here we go. So this is what we've just seen. Okay, we saw the radial head. This is the radial collateral ligament, okay, or lateral collateral ligament. You can just about make out the bump there of the radial tuberosity. So that's where the biceps will attach into that point there. Just play this through. There's your capitulum, trochlea, coronoid. So we're going to focus on this area here. So there's your olecranon fossa right at the back. You can see the cartilage of those joints as they're really, really smooth. So there's your radial collateral ligament. Just pause that there. There we go. So this is what it will look like in the textbooks. It's kind of like a triangular shape as well, but with a point on the lateral epicondyle, and then it's merging into the annular ligament there as well. Just move that out of the way so you can see. And then there's the spinning action that we just saw. In fact, let's just play that back. As it spins, you'll be able to see this in a second. I'll see if I can pause it at the right spot. Hopefully. Oh, I just missed it. Okay, so just underneath here, when that span all the way around, the radial tuberosity span with it. Okay, so what will happen is your bicep insertion point, so the radial tuberosity, if you fully pronate, it will pull your bicep all the way through to what would then be the front of your arm. Okay, so if I see if we can, I shouldn't have worn a black top. Hold on a sec. Let me change the screen to this one. Okay, so I've got my bicep going into radial tuberosity there. As I bring my arm all the way around, it pulls the bicep tendon through, and the bicep tendon will end up here. Okay, on ultrasound you can see it at the front. You do what's called a cobra pose like that. Okay, so yeah, if you fully pronate, you don't have to do that, but you can see it popping out there. So your bicep tendon attaches into here on the radial tuberosity, but then as the radius spins, it will pull it through, and it will end up on the front just there. Okay, just a interesting fact. I think that's the thing with these bits of anatomy, is you always think of it in that natural position, but then as it moves, it changes everything, right? And so understanding that movement is really useful for some things. I mean, if you're going to get into imaging and stuff like that, then it's definitely useful. So there's your radial tuberosity there. So keep an eye on that as it spins in a second. Olecranon fossa, olecranon process, radial collateral ligament, annular ligament around, and then what's just down here? There it is there, look. You see it poke through? Yeah. So there's the ligament across. Annular ligament going around. And then there's the ulna without the humerus in. Yeah, so that's what it will look like without the humerus. So this is one of the reasons why we are likely to get a fracture in this area, because it literally is like a hinge. So that end bit of the bone can get fractured, basically. Okay, depending on what position your arm is in. What you'll be able to see in a second. So this is the annular ligament coming all the way around, and I'm not sure, Rahul, what they've got in India. But in the UK, we have got a crisp, a potato snack called a hula hoop. Okay, and you can Google it if you want to. But the annular ligament looks like a hula hoop. All right, so there's the ends of the bones. Nice white cartilage there, so you can see where they articulate, where they join, and then there's the end of the radius just there. So like I said, there's a concave nature to the end of the radial bone, so that it can glide around the capitulum, but also spin on it as well. So the design is pretty good. So you can see the annular ligament coming all the way around here. Yes, remember, anterior to posterior radial notch. So that's it there. You've got the join between the ulna and the radius just there. There it is spinning, and there it is without, and there's your hula hoop. Okay, so we've got this hula hoop shape all the way around. So that's where your radial head will fit in and allow that spinning to occur just there. It's a really, really clever design. Okay, so that's all connective tissue, and then that bit there is the bone. So that's where it articulates the join just there. Cool. That's why it's my favourite. I love that one. Okay, and then here, just a different name. Okay, cool. You'll get the idea. Okay, so we've got MCL and LCL, or radial collateral and lateral and ulnar collateral ligaments. So let's have a look at those. Okay, so again, this is what they're like in the books. I'll go through these after we've had a look at the video. So this is the ulnar side. So it's like, so that triangular type shape. So radial collateral we've seen before. Just move me out of the way. Merges in with the annular ligament, which allows that spinning to take place, so the radial head. And then, yeah, so it's the cut line of the ligament just there. So the ligament will actually extend a little bit lower than that. They don't just stop. Yeah, they merge into things. They merge into other connective tissue. So there'll be other connective tissue that will then carry on down the forearm that ligament will attach into. But there will be a point where you can see that there's a bit of a changeover in the tissue structure. All right, so that you can kind of make out like a delineation of the two, but basically everything merges together. And then this is the ulnar side, so the ulnar collateral ligament, and very, very flat. Yeah, so on the pictures in the textbooks, they look like bands of tissue, but in real life, it's like a flat covering. Okay, so there's the epicondyle, and it attaches all the way around the ulnar just there. So there's your radial collateral. There's the capsule of your elbow. So obviously in the other images that we've seen, the capsule has been removed so that we can see the joint. But the joint is surrounded by this capsule, which will then have synovial fluid or a synovial membrane so that synovial fluid can be produced. Floods the joints with synovial fluid so that they can nice and smoothly move around. Okay, so that's where the oiling of the joints come from, is that capsule. And there it is at the back. Yeah, so quite similar in terms of structure, like with the shoulder, where there will be, depending on what position the arm will be in, there'll be a time when the capsule is stretched. So when the arms flex like this, the back of the capsule will be stretched, the front of the capsule will be loose, and then when you extend, the front of the capsule will be stretched, the back of the capsule will be loose. All right, so that it will change depending on the position of your arm, much like the shoulder. So if your arm is up, the bottom part of the capsule will be stretched, but then when your arm's down by its side, it will all be squashed together and it will be loose. Okay, so it will change as we go. So yeah, this one merges into the annular ligament, which wraps around the radial head and the neck. Just show you that again, just go through that again. Okay, so radial collateral, annular ligament. So there, like I say, there was the cut end, but obviously it's more continuous than that. It does keep going. And then there's the ulnar side. So it's more like a sheet of ligamentous tissue. And there's the epicondyle just there. Attaches all around there. Okay, and again, front of the capsule just there, you can see that. You see that it's like the ligaments merge into the capsule. Everything merges in together. And because bits of the distal part of the forearm have been removed, that capsule would be continuous coming down as well. Annular ligament just there. Perfect. Okay, so if we have a look at the images of that, so these are usually what you see in the textbooks. So this is the radial collateral ligament just here, annular ligament underneath. All looks nice and neat, doesn't it? And you can kind of make every bit out. But as you've seen from the cadaveric specimens, they all merge in together. On the collateral, just here, and these are descriptions as well from the Trail Guide to the Body of how to locate these ligaments. So if you have somebody with an issue around this area, you can palpate these areas. The only problem is there's a lot of other tissue around here as well. So if you palpate this area and it's sore, it's very difficult to say, oh, you've got a problem with the ulnar collateral ligament, because there are loads of other muscles and tendons that attach into here as well. So you can't be very specific with palpation on its own. Just down here, something we haven't mentioned, that's the olecranon bursa. So there is a fluid-filled sac on the bursa, on the olecranon to protect the elbow. And I had a patient once with bilateral olecranon bursitis, and so both elbows were inflamed, and sometimes it's called student's elbow. So when you're leaning on a desk for a long time doing your revision, of course, anatomy revision, then it irritates the bursa, and then you get an inflammation in it, so it becomes a bursitis, and then the inflammation creates this lump on the end of your elbow. Okay, so that's that blue area just there. Okay. Cool. And then, yeah, this is kind of everything merging in together. So you've got capsule, collateral ligament, annular ligament, ulnar collateral ligament just there. So it's all, that's probably the most realistic picture actually, where everything's all in together. And then that bit there, that's your tendon from your biceps attaching into your radial tuberosity. Okay, just there. You've also got another bit of connective tissue that is really, really strong. Okay, just checking time, we're good. So we've got interosseous membrane. There are a few of these in various different parts of the body, and they obviously serve a purpose. What they do is they provide a divide between the front and the back part of the body, or sides of the body, depending on where it is. So this interosseous membrane is a connective tissue that connects your radius to your ulna, and it's like a sheet. So it goes all the way up and down radius and ulna. And the useful part of that is the tendons and the blood supply and the nerve supply from the anterior part of the arm will rest on that surface of the interosseous membrane, so it will come up this side, and then on the posterior part it will rest on the other side. So they're kind of separated from each other, and they use the interosseous membrane like a bed, okay, and as they're guiding towards, in this case, the wrist. It's not so much of a problem in the forearm, although you can get it, but in the lower limb, so between the tibia and the fibula, you can have something called compartment syndrome. So if you have a bleed or inflammation, an infection, something like that within one compartment of the lower leg, it will swell, but then it can't go anywhere because it's pushing against this interosseous membrane. And it's a medical emergency if it's a bleed, because you're bleeding into that space. So there may be a fracture that's nicked an artery or something like that, or like I say, some kind of infection where the inflammation is just spreading really, really quickly. Again, not so much of an issue in the forearm, but just to kind of highlight that this interosseous membrane is solid. It's really, really, really tough. It's tougher than your bone. So if you break your forearm, so a radius or ulnar, then the bones will break before the interosseous membrane. Okay, it's really, really tough stuff. Yeah, there you go. So very strong. Bones will break before it tears. All right. The good thing with this piece of connective tissue is, as well, we've got some attachments for muscles. So, but in the middle of the joint as well. So that's quite useful in this area, because there's loads of muscles all going off in different directions, and you kind of run out of bone to attach to. So we've got some connective tissue where the tendons of those muscles will attach. Okay, so again, just something to think about when we go on to the next bit. Talked about the olecranon bursa. So easily irritated, like I said, student's elbow. So if you're leaning on a desk for a long period of time. Cool. Connective tissue sorted. Right, let's have a look. What have we got? Right, let's go through these movements, and then we'll start the muscles next week. Okay, so I'm going to give you a bit of an introduction to the muscles here. Right, so we've got two main elbow movements, and we've talked about these already. So flexion, bringing your arm towards you; extension, taking your arm away. And then with the elbow bent, you've got pronation, supination. So bowl of soup, and then the other one is pronation. So these two movements take place at different parts of the joint, and hopefully now you've seen the inside of the joints, you can see how it all kind of fits together. Okay, so two movements at the hinge joints, two movements at the pivot joint, and the pivot joint is that radial head. where it rotates around. Yeah, the ulna doesn't pivot. The ulna stays still. It's the radial head that rotates. Okay. Cool. So before attending class, I feel I know a lot about it because it'll show me. Thank you. Thank you very much, Rahul. Thank you. Please spread the word in India. Happy for you to do that. Okay, so we've got elbow movements that occur. So flexion, we've got the radiohumeral joint, which we talked about before, and the humeral ulnar joint. And the muscles that cross those joints and bring about these movements are your biceps brachii. So that's your main kind of bicep muscle. A muscle called brachialis, which is a really big muscle that people forget about. It's underneath your biceps. And then another one called brachioradialis. All right. So you'll notice that the name brachii or brachy is in a lot of these words. And the brachial region is the humerus region of your arm. Okay, so that area there is the brachial region. So you'll have like brachial artery is in this area. All right, so it's that specific region. So extension wise, we've got two main muscles that bring about extension. We've got triceps, and you can pronounce this a couple of different ways. So anconeus or anconeus, however you want to pronounce it. So we've got those two muscles there. We'll have a look at those. Supination, so bowl of soup. Again, we've got the biceps. We've got a specific muscle called supinator. Yeah, so that's one of those where it does exactly what it says. Yeah, and then we've got brachioradialis, which is not a prime mover of supination, but will certainly assist that movement. Okay, so it's a helper to these two. And then pronation is your superior radial ulnar joint, so that's where your radial head attaches onto the ulna. We've got pronator teres, okay, pronator quadratus, which is further down the arm, okay, so that's more towards the wrist, but pronator teres is around the elbow, and then brachioradialis again, which is another assister of pronation. Yeah, so pronator teres, pronator quadratus, brachioradialis. So if you're doing exams and you're assessing different movements and somebody can't do a particular movement, if the joint is okay, so the joint feels as if it's moving okay, it may be a muscle issue, like they can't activate the muscle for whatever reason. Maybe there's an injury to it, or whatever you're looking for. But these will help you kind of hone in on certain muscles for certain movements if you're doing assessments. Cool. Okay, we have got a bit of time. Let's do this one. We'll do biceps, and then we'll wrap it up. Biceps, two heads on the brachial region of your humerus. Yeah, so that's why it's called what it is. So we've got one insertion down here onto the radial tuberosity. So that's where in all the textbooks it will say that the biceps will attach onto the radial tuberosity. But if you notice on this picture, there is a kind of spreading of the tendon because it merges into the fascia of the forearm. All right, and I'll show you this on the video in a sec. At the other end, we've got two attachments. So the long head of the biceps comes up through here, through the bicipital groove, which we looked at when we looked at the shoulder, over the top of the humeral head, and then onto the top part of the socket. And again, we looked at that during the shoulder. Okay, so we're not going to focus on this area too much because we've already done it. And then this one here is the short head and attaches onto the coracoid process just there. So we've got these two heads, one attachment down at the bottom, splits into two attachments at the top. Okay, let's have a look at those. There it is. Move that to the top. Here we go. Okay, we'll do this and then I'll see you next week. So bicep brachii. Here we go. So that's the image you've just seen on the PowerPoints. Again, these are really useful for revision if you want to take a screenshot. And here we are. So there's your biceps brachii. Now, usually cadaveric specimens are quite old. You'll notice that the musculature isn't very big. You're expecting big bulging biceps. This is probably the body of a 70 or 80-year-old person. So the musculature is quite small. Here's your radius down here. Here's your bicep tendon coming down. So you can see the split in the muscle here, and then you can see it's covered at the top just there by another muscle. So we're going to have a look at that as we go up. Brachialis is underneath. Okay, we'll cover that on the next week. So as we come up here, it gets covered. So we've got deltoid covering it and your pec major. So if we take those out of the way and the pec major out of the way, now we can start to see the tendons underneath. Okay, I'll just play that through again. So we've got short head down here, long head here. There's your deltoid, there's your pec. So deltoid will be reflected, pec major will be reflected, and then you'll be able to see the biceps underneath. So that's how deep the biceps are. So deltoid back, then your pec, and now we can see that long head of biceps tendon just there. So it's going in between the bicipital groove and then that one onto the coracoid process just there. Okay, so you can see, follow it up there. So that's how it splits. That's what it looks like. So there's your coracoid, there's your bicipital groove just there. So as it comes up, it then goes into where the capsule is of the shoulder. So it comes up this area here, over the top of the humeral head, and then right onto there. It's called the supraglenoid tubercle. And again, we covered that in the shoulder. So here we are. This is the bit I was more interested in. So we've got a very broad, flat aponeurosis. So it's this kind of sheet of connective tissue. So it's not just a tendon just inserting on the radial tuberosity. It's this spread of connective tissue attaching quite broadly to the forearm. Yeah, so that area down there. So there's the radial tuberosity. There's the aponeurosis. And then that's what it looks like in real life. Yeah, so it's continuous. So there's the bicep coming down there, and it's continuous, this aponeurosis, with the superficial fascia of your forearm. Yeah, so that bicep really, really powerful. It's got all of this connection in your forearm just here, as well as that insertion point on the radial tuberosity. So look at that. Yeah, so all of that is bicipital aponeurosis all the way down. Look at how it wraps around. So it's literally just merges into your forearm. So it's going to bring about flexion, and it will also bring about supination. So spinning the radial head. There you go. Cool. Biceps is a good one. Brilliant. Thank you for joining me this morning. Yeah, hope everything's all right with your dog, Caroline. I know what it's like. I've got 3 dogs. I'd hate for anything to happen to them as well. So I hope you're okay. And I will see you next week. I hope you have a good week. We're going to carry on with the muscles of the elbow. Like I say, there aren't very many. So because we're going to cover the wrist bit on another session. So we'll probably be onto the nerve and the blood supply quite quickly for this area. Okay, cool. See you next Monday, 10 o'clock.